Sir.
Good morning, Carolyn and everybody. We have a technical issue today.
Okay.
I have a patient who's not doing well and needs my attention, so I am scheduled to speak with them at 9:30 my 10:30 my time. So we have a half hour. We have 20 minutes.
Wonderful. So I'm going to speak really super fast. We are all about progesterone today. Welcome to you. Welcome to everybody. And prayers up for your patient for sure.
Thank you. Yeah.
Indeed. The prayer avalanche works. So today we're all about progesterone. So I'm just going to fly through these. This woman is really struggling with estrogen and progesterone, tolerated progesterone prior to menopause, now makes her feel awful. She is using the menopause method oils, but right now she's only taking testosterone. She knows it's not ideal to just use testosterone, but she's wondering your thoughts on that for now.
In many instances, there's insufficient information for me to give a good opinion.
Yeah.
And this is what comes to me. If she's using the oils, it's likely that she's linked up to a provider that has a certain smaller, medium knowledge of what we teach. There are providers who have certain level of skill and knowledge in treating women in menopause, and they find our oils and they don't necessarily connect with us and really understand the method. And then sooner or later, usually sooner, individual challenging situations come up. And do not be concerned. I mean, I can't tell you. I was asking one of our favorite providers, she's a compounding pharmacy that advises physicians. She sees 5 menopausal patients a day, 5 days a week, and she's been doing it for many years, and she knows our system really, really well. And just for fun, I asked her, Mary Lee, when you stop and think about how many straightforward, simple menopausal patients do you find that you encounter? And she said 0. Where everything is perfectly smooth and it's easy. Now, I wouldn't be discouraged about that at all, because if you get on hormones, you're going to do some good. If you don't get overdose, and these hormones are so strong, if you get an overdose, most of the time, not all the time, you're not going to like it. So if you don't like it, I mean, the only acceptable outcome we have when we're treating women with hormones is you feel better.
Correct.
If you don't feel better, something's not quite tweaked into where it needs to be. And it's so rare to work with a woman where we don't get it sooner or later. And, I must say, sometimes it's a year or two, a lot of tweaking, a lot of changes. We're trying to replicate a woman's brain that used to manage the menstrual cycle with just such exquisite elegance. It's astounding. It's staggering. Want to believe in the divine, just study a woman's menstrual cycle. But the orchestration of that was done by some central operating system that decides that it's no longer a great idea to produce babies, and those ovaries stop working. And then we step in with our minds and our experience and try and put it back together again.
I guess there's a movie called Frankenstein one time put out there where he was like thinking maybe along those lines of trying to create a new body, and you guys have perfected it.
I wouldn't necessarily use that analogy.
Well, I'm kind of teasing.
It's so rare that if given enough time and if we hunker down, we figure it out. And then once a woman figures it out, it's a cruise. You can go 10, 20, 30 years in these hormones, but sometimes it takes a while to figure it out. And so there's some things that aren't understood or known here. Now, I don't know enough about the case.
Got it.
So what I invite this woman to do is, if she's actually did I get that right, Carolyn? She's actually using the menopause method oils?
Yes.
that she asked her provider to connect with me directly
Okay.
and see if I can help a little bit sorting it out. I
Oh,
may or may not be able to because of the number of commitments that I have.
you're the most popular man on the planet, I'll tell you.
I got to furnish, she has to furnish a lot of information, her age, her weight, her health past. We have a 12-page questionnaire that we have patients fill out, and we learn a lot about them in the very first visit. And then, yeah, there's a way. There's always a way. And yeah, don't be discouraged because you're having a challenging time in the beginning. I can't tell you how many times I have met up with a challenging time. And just keep working it. You keep working the details, the angels in the details. Keep working those details.
I love
And
that.
very, very rare that we can't figure it out.
Okay. Well, so that.
Sorry, it's not a very complete answer, but there's not. I don't have enough information.
Well, I think it's very soothing to hear that we don't have to be like terrified.
Yeah.
You know what I
You
mean?
know, healing is possible. There's always a way. Your body knows these hormones. You go into menopause, you lose your ovarian hormones. And then it's sometimes there's receptor site issues, sometimes there's other confounding issues. But there ultimately there's a way to heal. Sometimes, yeah, there's all kinds of different paths to go, but ultimately there's a way to heal. And
I don't know if you can hear me, but you're frozen. There you are.
it's an actual patient that I can legally treat, and she's in our program. We just go day by day. Anyway,
All right.
have heart, you'll solve it. I can't tell you how many women I have encountered that they've gone through 5 different providers. They just can't seem to get it right, and it's very, very stressful, and they lose hope. And we've run into this so many times. And then, lo and behold, healing is possible. Hunker down, turn on the metaphorical microscope, figure out what's going on because something's going on. You know, it's not, it may sound mysterious when you're dealing with it, but no, lift up the covers. There's stuff going on in there. And so pull back the curtain like they did in that famous Judy Garland movie, Wizard of Oz. Pull back the curtain. There's stuff going on in there. You figure it out.
So we could just click our heels and.
Yeah. The main thing I want to say is I can't tell you how many times we've met up with women who are having a rough time. They can't seem to figure it out. They're trying to figure it out themselves, or they've worked with several healthcare providers who aren't specializing in this. It's part of a small part of a big practice. And how many times just put your shoulder to the wheel, we figure it out. So what I'm really wanting to say is have hope. This stuff is solvable no matter how confounding it's been.
Yes. Oh, and thank you for that because it brings a lot of feelings of security, let me say. So I'll move on to our second question that again has to do with progesterone. Stating Dr. R has often said it's okay to take estrogen and testosterone without progesterone for the few women who cannot tolerate it, but I'm wondering if he worries about progesterone countering estrogen. I'm also wondering if the need for progesterone to protect the uterus is a myth. Thank you both for the work you do.
Good question.
Yep.
We're designed to have a flawless amount of excellent biochemicals, thousands of them, to deal with our trillion cells, or I don't even know how many there are, and the trillions of biochemical reactions. Everything should be perfect. Oh, guess what? We're humans and we're not perfect. And we can't control or administer the precise amount of every molecule that we need. And I don't worry about it. Yes, we love progesterone. Yes, women's bodies love progesterone. And of course, we want to get progesterone right. And yes, progesterone does balance estrogen. And in a woman who's taking robust amounts of estrogen, in menopause, you need the progesterone to balance the estrogen so you won't form an endometrial lining and bleed. Not enough progesterone, you bleed. Not enough progesterone, some women don't sleep, don't protect the bones. But there are 1,000 moving parts, and we always do the best we can, and we're not about perfect. My God, how many of you out there are perfect and everything's going right and you're eating just the right number of molecules and doing the perfect thing day in and day out? No, we're not striving perfection. We're going for good enough. And I assert this, that every woman in menopause can get hormonal balance that's good enough. So, but it comes down to the details. We know a woman needs estrogen and testosterone. Absolutely. We always love to give a woman progesterone. Always. We always start every woman on progesterone. But there is a rare case where the women do not tolerate the progesterone, and there's even workarounds for that. There's a lab, Meridian Valley Lab, call them up. It's affiliated with Dr. Jonathan Wright. They're good at sorting out progesterone allergies.
Meridian Valley Labs.
Yes, Meridian Valley Lab. They
Okay.
have techniques to sort out progesterone allergies, because eventually, if you can't get the progesterone to work, you try and sort out why isn't it working. Is it a receptor site issue? Is it an allergy to the progesterone you're using itself? Is it an allergy to the base? But at any rate, sometimes a woman's been without progesterone for just long enough that it seems to me like her receptor sites get so dormant that you've got to start out with super low dosages. For example, the progesterone that we prescribe is 200 milligrams per milliliter. It's 8.7 milligrams per drop. I've had patients where I've dropped that down to 5 milligrams per milliliter. What is that? That's 1/40th the strength. And we start with one drop and see if they'll tolerate that one drop. If they do, we gradually increase it. And we're playing with individual hormonal entities here. We get the bias right. We start low, gradually increase, alleviate symptoms, don't go into overdose. We start the testosterone and DHEA low, alleviate symptoms, get into the proper zones. And if we have to start the progesterone super low, we do that. And you know what? I can think of one woman who actually comes on to our Facebook Live periodically, that she has trouble with progesterone, and my God, she has to take a minuscule dose. But she's doing really well, and she's getting adequate estrogen, and she's getting adequate testosterone, and she's doing really well. And it's a very minimal amount of progesterone, and you don't sweat it, because of the 82 jillion molecules you need in perfect balance to be perfect, what percentage of your molecules, including your hormones, are you going to get perfect in this lifetime?
Right. Right. It's a good point. Is the need for progesterone to protect the uterus a myth?
It's an ongoing challenge, but major improvements take place, including protecting the bones, protecting the muscles, protecting the vagina, protecting the brain, protecting the arteries. These are achievable.
Okay. Thank you. Moving on. Do we strive to attain and stay within lab ranges with our hormones? My estradiol and DHEA are all high and out of range, but my progesterone is low but within range. This is very confusing to me. Is that bad?
Well, for one thing, there's a need for a lot more information. Laboratory ranges. What ranges are you talking about? Is this blood tests?
Yeah, I don't know.
What kind of ranges? These are based on 20 to 29-year-olds, or very often they'll list the various age groups. But let me tell you about the laboratory. When a woman is 20 years old, her hormone levels are at the absolute highest they're going to be, plus or minus a couple of years. And then she's going to gradually diminish. And maybe by her 30s even, she's getting into progesterone and estrogen declines and imbalances that are getting her a little symptomatic. But it's tough to test her. Because what day of the cycle are you going to test her? Well,
Right.
you always aim for when she's menstruating, about 3 weeks in, mid-luteal it's called, 3/4 of the way in her cycle. If she's regular. Oops, how many women are going to go see a doctor when everything's regular and perfect? No, that's not how it plays out. So
Right.
testing,
You're frozen, Dr. R. Uh-oh. Oh, I'm not sure if you can hear me, Dr. R. Sorry, ladies. There you are.
we test 100% of our patients by 24-hour urine hormone test. Oh my God, did I say 24-hour urine hormone test? Have you ever heard me say 24-hour urine hormone test
It's new to
on this
me.
program? Did I say 24 hours? I didn't say 5 points or 4 points or 4 different. I didn't say pee on filter paper, nothing like that. I said 24-hour urine hormone test. We test 100% of our patients. When I like to test them is not in the beginning of menopause, certainly not in the perimenopause, because their levels are so erratic that a woman could be having hot flashes from estrogen deficiency. But the day we caught her on was when she had a spike when her pituitary gland tried to urge that ovary to squirt some more out, please. We don't want you to stop. So you get this burst in the perimenopause. You're nice and even when you're young and cycling regularly. Not in the perimenopause, you start getting erratic. And of course, all of this, we describe this in the book, which you can download from the ins and outs of menopause.
Yes.
So we don't test in the perimenopause. Blood test, 24-hour urine hormone test, we don't do it because you can get deceiving results. And I've done that. That's how I learned that. Yeah. Tested a woman. She's having hot flashes. She said, I've got estrogen insufficiency. Tested her. She showed high estrogens because we caught her on a day in the perimenopause when her estrogens were high. I tell her I want to treat you with estrogen. She goes, what? You're a doctor? You just tested me and I've got high estrogens? You want to treat me with estrogen? Let me out of here, please.
I'm sorry.
That's how I learned this. But what we know, we don't want to test a woman at the beginning of menopause when she hasn't had a period because all of her hormone levels are going to be low. So you want to get her to pay the $300 that she's going to need to pay for a 24-hour urine hormone test to learn that her hormone levels are low. No, we don't do that. But we start a woman on dosages. She gradually increases those. She alleviates her symptoms of insufficiency. And then one day, happens sooner or later at the 2-month mark, at the 6-month mark, at the 1-year mark, usually at the 3-month mark. She says, wow, I feel better. And I think I found my dosages. And we test those women 100%. Now, it turns out, what ranges do you use to compare them to? Do you want to compare them to a 20 to 29-year-old? No way. We're not trying to replicate youthful levels. Young women have estrogens enough to create an endometrial lining and menstruate. They also get monthly breast glandular cell proliferation. They get mitosis of breast glandular cells, an additional cell in preparation for lactation, possible pregnancy. If she doesn't impregnate, those cells disappear, but we don't want to cause mitosis in a menopausal woman. We're not trying to replicate youthful levels.
Right.
In most, but not all, there's exceptions. Of course, there's exceptions. Relates to cognition, and I've spoke about this in this program.
Oh,
and
yeah.
I'll speak about it next week if you'd like.
Of course.
Now, she's alleviated symptoms. She feels pretty good. We test her. There are ranges that we have defined. I personally went into the medical literature and said, what's too little estrogen? What's too much? And we've defined those ranges, and the lab we work with actually publishes those ranges. On 24-hour urine hormone testing, that really matters. And what's too little? If you're not protecting the vagina, you're not protecting the bones. We know what the numbers are. We define it on that special 24-hour urine hormone test report. What's too much? Well, if a woman's getting breast glandular cell proliferation or she's bleeding, you're in too much estrogen, for example. Well, we know what those numbers are. Just for fun, it's 8 to 14 micrograms of total potent estrogens per 24 hours. That'll be meaningless to you. What about blood testing on a woman you're treating? Tricky. There are providers that have gotten really good at interpreting blood tests because they've seen hundreds of women and they've been doing blood tests. But when do you draw the blood? We had a woman had a blood test. She had taken her estrogen in the afternoon the day before. She got a morning fasting blood draw. Her estrogen levels came in super low. Why didn't she take it in the evening? Because some women can't take estrogen in the evening. They get too animated. They get too stimulated. So she
Yes.
had to take hers at 3 o'clock in the afternoon. Well, we're testing her blood when? 18 hours later. So she got super low levels, but her symptoms are alleviated. All of this is taken care of by doing the 24-hour urine hormone test. And so that's what we use. And we get wonderful results and we get the metabolites. And bottom line is, I have defined using the medical literature what is the optimal zone. You won't see that on blood tests. They don't define the optimal zone for treating women in menopause. And it ain't youthful levels, with some exceptions. Some women need to get that period back if they're losing their brain. We need to give them so much estrogen to get their brain to recover. That's worth it. We do that. That's worth it. It's a beautiful thing.
Right. And you always say never. And I think that that's
Exactly.
incredible, really.
And it just takes us back to the individual woman. This is the great art of treating women and men, by the way, in menopause and andropause. Is
Yes.
individualize the treatment, you'll figure it out. Now, if we could all just pause for a moment, a very special human being is is very ill, and I'm going to sign off today because I think I can help them by connecting him up with some special doctors I know. And this is the only window of opportunity I have in this very busy day.
Got it. And so, of course, our hearts are indeed out to him, and he's got the best doctor on the planet as far as I'm concerned. And God bless. And
So I'm going to see you all on Tuesday.
Indeed. And I'll have the questions and we'll continue on. And may he get well and better. And may you have a wonderful weekend. To all the women, I'm sorry we were short today, but it's a very good reason to be short today. So,
all righty. I'll see you later.
See you. Bye bye, Doctor.
Bye bye, everybody.